Hello everyone, this is Shanmugapriya. This lecture is about the topic diabetes mellitus. In this lecture, I will be comparing type 1 and type 2 diabetes mellitus simultaneously. So, let's get started. The contents of this lecture are definition, epidemiology, etiology, classification, physiology of insulin, pathophysiology, clinical features, screening, diagnostics, differential diagnosis, treatment, treatment algorithm for type 2 diabetes mellitus, and complications. So, let's get started. The definition. Diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia, that is, elevated blood glucose levels, resulting from defects in insulin secretion, insulin action, or both. The normal value of blood glucose is between 3.9 millimole per liter to 7.1 millimole per liter. There are two common forms of diabetes, that is, diabetes type 1 and type 2 diabetes mellitus. Next, in this slide, we are looking at the epidemiology of type 1 and type 2 diabetes mellitus. Type 1 diabetes mellitus is prevalent only in 5% of all the patients with diabetes, whereas type 2 diabetes mellitus, the estimated prevalence in US is about 9.1%. The onset of type 1 diabetes mellitus is in childhood, typically less than 20 years, but can occur at any age. It peaks at an age of 4 to 6 years and 10 to 14 years. In type 2 diabetes mellitus, it has an adult onset, typically less than 40 years. Mean age of onset is decreasing. Type 1 diabetes mellitus has an highest prevalence in non-Hispanic whites, whereas type 2 diabetes mellitus has an highest prevalence in Hispanics, Native Americans, Asian Americans, African Americans, and Pacific Islanders. Next, we're going to look at the etiology. Type 1 diabetes mellitus is caused by autoimmune beta cell destruction in genetically susceptible individuals. HLA association, HLA-DR3 and HLA-DR4 positive patients are 4 to 6 times more likely to develop type 1 diabetes. Association with other autoimmune conditions like Hashimoto's thyroiditis, type A gastritis, celiac disease, primary adrenal insufficiency. The etiology of type 2 diabetes mellitus is hereditary and environmental factors. Association with metabolic syndrome. Risk factors are obesity, high calorie diet, high waist to hip ratio, visceral fat accumulation, physical inactivity, first degree relative with diabetes, ethnicity, hypertension, dyslipidemia, and a history of gestational diabetes. Next, we're going to look at the classification. According to WHO and American Diabetes Association, diabetes mellitus can be classified as type 1 diabetes mellitus, that which is also called insulin dependent or juvenile onset diabetes mellitus, which can be further divided into type 1A, which is LADA, that is latent autoimmune diabetes in adults, and type 1B, that is idiopathic. Type 2 diabetes mellitus is also called non-insulin dependent or adult onset diabetes mellitus, which includes gestational diabetes. Other forms of diabetes are MODY, that is maturity onset diabetes of the young, genetic defects in the beta cell function. There are 6 types. The most common ones are MODY2 and MODY3. The other forms are genetic defect in insulin function, disease of exocrine pancreas, endocrinopathies like Cushing's disease, acromegaly, drug-induced diabetes, for example, corticosteroids, infections, for example, congenital rubella infection, glucocorticoid therapy, steroid diabetes, rare immunological diseases like stiff person syndrome. Let's look at the physiology of insulin. Insulin is synthesized in the beta cells of islets of Langerhans in the pancreas. The proinsulin is the precursor of the insulin, which produces, after cleavage, C peptide and insulin. This insulin has two peptide chains, alpha and beta chains. The action of insulin has metabolic effects on the body, primarily contributing to the generation of energy reserves and glycemic control. Carbohydrate metabolism includes insulin is the only hormone in the body that lowers the blood glucose level. Protein metabolism stimulates protein synthesis, stimulates amino acid uptake into the cells, and inhibits proteolysis. In case of lipid metabolism, it maintains a fat depot and has an anti-ketogenic effect. In case of electrolyte regulation, it stimulates intracellular potassium accumulation. Let's look at the pathophysiology of type 1 and type 2 diabetes mellitus. In case of type 1 diabetes mellitus, the pathophysiology involves genetic susceptibility or an environmental trigger often associated with previous viral infection, which leads to an autoimmune response with the production of autoantibodies, for example, anti-glutamic acid decarboxylase antibody that targets the insulin producing cells, which leads to progressive destruction of insulin producing beta cells in the pancreatic islets by autoreactive T cells, which leads to the destruction of 80 to 90% of beta cells and causes absolute insulin deficiency, which causes the elevated blood glucose levels. The pathophysiology of type 2 diabetes mellitus involves two main mechanisms. The first one is the peripheral insulin resistance. There are numerous genetic and environmental factors. The main one is the central obesity, which causes increased plasma levels of free fatty acid, which causes impaired insulin dependent glucose uptake into the hepatocytes, myocytes, and adipocytes. Increased serine kinase activity in the liver, fat, and skeletal muscle cell causes phosphorylation of insulin receptor substrates, causes decreased affinity for IRS1 for P13K, decreased expression of GLUT4 channels causes decreased cellular glucose uptake. The second mechanism is pancreatic beta cell dysfunction. Accumulation of proamylin, which is an islet amyloid polypeptide in the pancreas, causes decreased endogenous insulin production. Initially, insulin resistance is compensated by increased insulin and amylin secretion. Over the course of disease, insulin resistance progresses while insulin secretion capacity declines. After a period of impaired glucose tolerance with isolated postprandial hyperglycemia, diabetes manifests with fasting hyperglycemia. The clinical features of type 1 and type 2 diabetes mellitus are: in case of type 1 diabetes mellitus, there is a sudden onset. Diabetic ketoacidosis is often the first manifestation. Alternatively, children may present with acute illness and classic symptom. In case of type 2 diabetes mellitus, it has a gradual onset. The majority of patients are asymptomatic. Hyperosmolar hyperglycemic state in elderly, especially the signs of dehydration, are the first signs to be noted. Symptoms of complications may be the first clinical sign of the disease. The characteristic features for both type 1 and type 2 are the same. It involves a classic of 3P, that is polyuria, polydipsia, and polyphagia. And the non-specific symptoms are fatigue, visual disturbances, blurred vision, calf cramps, poor wound healing, pruritus. The most prominent feature for type 1 diabetes mellitus is weight loss. A thin appearance is typical for type 1 diabetes mellitus, and the prominent feature for type 2 is benign acantha's nigrans. Diabetes mellitus screening. In the screening, if a person comes with the signs and symptoms of hypoglycemia, we go for a single random plasma glucose. If the single random plasma glucose is greater than or equal to 200 mg per dl, we diagnose the patient to be diabetic. If a person comes with signs or symptoms of hyperglycemia, we check for the signs and symptoms of hyperglycemia. If the signs and symptoms aren't present, then we check for obesity or any kind of risk factors. If any risk factors is positive, then we screen them for fasting plasma glucose or oral glucose tolerance test, 2-hour plasma glucose, where fasting plasma glucose, if it is greater than or equal to 126 mg per dl, or oral glucose tolerance test is greater than or equal to 200 mg per dl, we diagnose the patient to be diabetic. If the fasting plasma glucose levels are from 100 to 125 mg per dl, and oral glucose tolerance test from 140 to 199 mg per dl, then we diagnose the patient to be pre-diabetic. If the fasting plasma glucose level is less than 100 mg per dl and oral glucose tolerance test is less than 140 mg per dl, the patient is healthy. We also screen them for hemoglobin A1C test. Hemoglobin A1C test is a very good marker to see the glycemic control for the last 3 months. So if the values are greater than or equal to 6.5%, then we diagnose the patient to be diabetic. If the value is from 5.7 to 6.4%, we diagnose the patient to be pre-diabetic. And if the value is less than 5.7%, we diagnose the patient to be healthy. We also have to screen for this screening should be conducted for all the patients who are greater than 45 years of age. Next, we are going to brief the diagnosis. Symptomatic patients. If there are signs and symptoms of diabetes, we go for a single random blood glucose level. If it is greater than 200 mg per dl, that is sufficient for the diagnosis. If the patient is asymptomatic or he is obese or he is having any risk factors, and if the age of the patient is less than 45 years, we go for an alternative, a pathological fasting plasma glucose test or a oral glucose tolerance test or a hemoglobin A1C test to establish the diagnosis. If hyperglycemia is high enough to suggest but not confirm a diagnosis of diabetes mellitus, two similar test results, either from the same sample or from a separate test sample, will confirm the diagnosis. Next, this is the values for the fasting plasma glucose, 2-hour glucose value after oral glucose tolerance test, and a hemoglobin A1C levels to put the diagnosis for diabetes mellitus or prediabetes or healthy. If the fasting plasma glucose is greater than or equal to 126 mg per dl or greater than or equal to 7.0 millimole per liter, or a 2-hour oral glucose value is greater than or equal to 200 mg per dl or greater than or equal to 11.1 millimole per liter, or a HbA1c value is greater than or equal to 6.5, we can diagnose the patient to be diabetic. If the fasting plasma glucose is from 100 to 125, a 2-hour glucose tolerance is from 140 to 199, and a hemoglobin A1C is from 5.7 to 6.4, we diagnose the patient to be pre-diabetic. If the fasting blood glucose is less than 100, or a 2-hour glucose value after oral glucose tolerance test is less than 140 mg per dl, or a hemoglobin A1C level is less than 5.7%, then the person is healthy. Next, there are a few additional tests which differentiates between type 1 and type 2 diabetes. In case of type 1 diabetes mellitus, there are specific autoantibodies for diabetes mellitus type 1, like anti-GAD antibodies, antithyrosin phosphate related islet antigen IA2, or islet cell surface antigen ICSA against ganglioside. C-peptide is a very important test which differentiates between type 1 and type 2 diabetes mellitus. If the value of C-peptide is less, which indicates an absolute insulin deficiency, it is type 1 diabetes. If the value of C-peptide is increased, it indicates insulin resistance and hyperinsulinemia. So it is type 2 diabetes. Urine analysis. Microalbuminuria is an early sign of diabetic nephropathy. Glucosuria, testing urine for glucose, does not suffice to establish the diagnosis of diabetes mellitus. Ketone bodies, usually accompanied by glycosuria, positive in acute metabolic decompensation diabetes mellitus, like diabetic ketoacidosis. Next, we are going to differential diagnose type 1 and type 2 diabetes mellitus. Type 1 diabetes mellitus has a relative frequency of 10 to 20%, whereas type 2 diabetes mellitus has a relative frequency of 80 to 90%. The genetics of type 1 diabetes mellitus is positive HLA association, whereas type 2 is a negative HLA association and a strong genetic predisposition. The pathogenesis of type 1 is absolute insulin deficiency, whereas the pathogenesis of type 2 is insulin resistance. In case of obesity, type 1 has no association with obesity, whereas type 2 is strongly associated with obesity. The onset of type 1 is an acute decompensation, typically at the age less than 20 years, whereas in type 2 there is a gradual onset, usually at the age greater than 40 years. The C peptide is decreased or absent in type 1, whereas it is initially elevated in type 2. The metabolism is unstable in type 1, and whereas type 2 is stable. Risk of ketoacidosis is high in type 1, whereas low in type 2. The treatment for type 1 diabetes mellitus is insulin therapy, whereas in case of type 2 diabetes mellitus, lifestyle changes, oral anti-diabetic drugs, and insulin therapy. Let's look at the treatment aspects. The aspects of treatment: lifestyle modification. We ask the patient to increase physical activity, which will lead to decreased blood glucose and therefore increased insulin sensitivity. Smoking cessation should be advised. Balanced diet and nutrition. Small frequent meals. Diet should be composed of 55% carbohydrates, 30% fat, and 15% protein. High fiber diet is recommended. Alcohol should be stopped. If possible, should be consumed with carbohydrates to avoid hypoglycemia. The medical treatment includes oral antidiabetic drugs, insulin therapy. Patients with prediabetes usually do not require medical treatment but do benefit from a healthy diet, weight loss, and exercise. And here is the anti-hyperglycemic therapy algorithm for type 2 diabetes. We should achieve an HbA1c target for adults less than 7%, that is 53 millimole per liter. The guidelines for the treatment of diabetes mellitus recommended an individualized treatment strategy. If the target A1C is not reached within 3 months with conservative measures, that is, diet and exercise, the next step in the therapeutic algorithm should be initiated. So, first we initiate a general measure of weight reduction, exercise, medical nutrition, therapy, self-management education. If the glycemic control is not achieved, next we go to the monotherapy, where the first line of choice, the drug of choice is metformin. Next, if the hyperglycemic control is not achieved by metformin, we go for the dual therapy. We add an extra anti-diabetic drug along with the metformin, which can belong to dipeptidyl peptidase 4 inhibitor class, sulfonylureas, or an amylin analog. We can also add a GLP-1 receptor agonist like or incretin mimetics along with metformin or a basal insulin. If still the hyperglycemic control is not achieved or the glycemic control is not achieved, then we go for a triple therapy. Along with the dual therapy, we either add a third oral anti-diabetic drug or a nightly basal insulin or an injectable GLP-1 receptor agonist. There are combination injectable therapy also, like metformin plus a basal insulin plus a mealtime insulin or a GLP-1 receptor agonist. Only consider the substitution of drugs in cases in which the drug is not tolerated or side effects occurs. Next, the mainstay in diabetes treatment is to monitor the complications. Regular monitoring of the weight, abdominal circumference, blood pressure, blood lipids, renal retention, parameters like creatinine, electrolytes, injection site in patients receiving insulin therapy is a mainstay. Early eye exam in type 1 after 5 years with diabetes mellitus or after the age of 11 years, more frequently in patients with abnormal findings or diagnosed retinopathy. Annual urine testing for microalbuminuria, foot exam for neuropathy and ulcers. Advise the patients to wear appropriate footwear and avoid injury. Routine screening for psychosocial problems, including signs of depression and cognitive impairment, should be checked. Pneumococcal vaccination should be administered accordingly. This lecture doesn't include the treatment for type 1 diabetes mellitus. I will be making a separate lecture on the treatment and insulin regimes for type 1 diabetes mellitus. That's it for today. Thank you all for watching. Please do like, share, and subscribe to my channel. I will make more medical related videos and have a wonderful day.